Yeah.
Sure.
Hello, everybody. Welcome to World Sleep Day 2025. Obviously, this webinar is timeless. They are in Canada, in Toronto. I am in England, in Leicester, and you might be in any part of the world. But we are going to see this very important subject, which is putting trauma to sleep. The new book released by Jaan Reitav and Celeste Thirlwell. Welcome both my good friends to this webinar, to World Sleep Day. I am Professor Carlos Rivas Echeverria, GP with a special interest in sleep medicine here in Leicester, also in Mallorca, Spain, and also in Venezuela, Latin America. Sleepcareclinics.com. And I have the privilege and pleasure to present my good friend, Celeste Thirlwell, who I met 15 years ago, maybe more, in
2013 World Sleep Conference in Valencia, Spain.
Exactly.
At the insomnia seminar. And you asked me what I do with insomnia, and this book, which Dr. Jaan Reitav, psychologist, and I took 5 years to write, is my answer to your question. So it's taken me close to 12 years to answer your question, but the book has all the answers.
I must admit that I haven't been able to read it because it's fresh. You may get in your hands. Be careful.
Exactly. These are fresh.
Only
fresh
one month ago. 1 month ago.
Yeah, February 18th.
It came less than 1 month ago. So Celeste Thirlwell is a neuropsychiatrist and a sleep specialist in Toronto, Canada. And Dr. Jaan Reitav is also a clinical psychologist with a long experience. Both of them altogether more than 50 years of experience in sleep medicine. He works in sleep medicine and cardiac rehabilitation. And they wrote this wonderful book, which is indispensable because all of us may have trauma, physical, psychological, and this progresses to sleep problems, like one of the worst of them, insomnia, with all the consequences. But we are presenting this book today and this webinar because it's World Sleep Day. Jaan, what do you can you tell us about World Sleep Day?
Well, thank you for asking me, Carlos. World Sleep Day has been one of the, I think, most important days for people working in the sleep area because it is the day that we reach out to the community, to everybody, our neighbors, our friends, people we work with, to basically explain to them that sleep is indispensable to your well-being, that without proper sleep, you are going to have many potential difficulties. Some of them may be emotional, like feeling anxious or panicky or distressed. Some of them may be physical, like having difficulties with digestion, increased levels of pain and back pain and so forth. All kinds of things begin to happen when your sleep goes off the rails. So World Sleep Day is one day in the year where we reach out to the whole community and say, pay attention, watch what is going on with your sleep. It does make a difference for you in terms of your overall health and well-being. And we hope that today's webinar is helpful in giving people more education, more ideas about how sleep is important and what they can do to improve their sleep.
Exactly. I want you, my dear audience, to be the owner of your own health, having the tools that you need to have, and this, as our World Sleep Day logo says this year is a priority, is indispensable. Actually, you work in cardiac rehab. What's sleep got to do with cardiac rehab? What that does it have to do with the heart? People may think. So this is why this day is important. Can you briefly say what is the relationship between the heart and sleep?
Absolutely. Thank you for asking, Carlos. So, one of the things that we discovered in writing the book is that there is an area in the brain, very deep in the brain stem, that is responsible for survival. So for you and for me and for all of us, survival is the absolute most important thing that we need, right? If we don't live to tomorrow, then everything else doesn't matter. What food we eat, how smart we are, etc. So survival is the responsibility of one small area of the brain called the locus coeruleus, or the blue dot. It's Latin for blue dot. And that area, when you are experiencing any kind of threat, and that threat can be from outside the body, as in a lion that may want to eat you for its lunch, or it can also be a experience from inside the body, like having a heart attack, that intense physical pain. And it is going to immediately get the attention of that locus coeruleus, and it is responsible for our cognitive functioning. So it wakes up the mind, but it results, for humans at least, in more worry, more distress about what's going to happen to me. That locus coeruleus also activates the periaqueductal gray, which is the seat of our emotional responses, our fight or flight reactions. So it activates the body in very strong ways. And more importantly than that, it also has an impact on the cardiovascular system, so that the cardiovascular system, when you are in some danger, shifts from its normal everyday 70 beats per minute up to a place where the parasympathetic nervous system just shuts down and your sympathetic system shoots up and your heart rate goes up to 100, 110 or higher beats per minute. And so there's this shift in cardiac functioning that is part of your stress response. And the patients that I work with here in the cardiac rehab center have not only a medical issue that needs attention, that is, their heart has to be looked at and they be given a plan for getting well, but as well, their emotional responses to their heart condition also needs to be taken into account, because many times these patients will feel anxious and panicky after their heart event. And some of those reactions in the nervous system, in the autonomic nervous system, continue on for months or even years. So that fact that the autonomic system can become dysregulated because of different kinds of danger is what disrupts sleep, is what perpetuates mental conditions like panic and depression, and also makes it harder for us to recover physically.
Interesting. Actually, it's so interesting that many of our colleagues, doctors, health professional in general, that are watching us now may think, oh, it makes sense because there is a science behind all this. We all thought, even myself, when I was an ignorant in sleep medicine, well, this sleep must have to do with our thoughts, our mind, but it doesn't have to be with this. And so it's a lot of, well, we got the Nobel Prize because of this research. interesting. So yes, please tell me, both of you, Celeste and Dr. John, why are you working in sleep medicine? Because you are a psychologist, John, and Celeste is a psychiatrist. Why are you working in sleep medicine? Why did you start? How did you become a sleep consultant?
Well, to me, sleep is the fire alarm of the body. Once a person stops sleeping properly, we know something is wrong. There could be something wrong mentally, there could be something wrong hormonally, there could be something wrong with the inflammatory system. But any patient that you come across who isn't sleeping well, you know something is out of balance. And for me, my fascination with sleep came about through really a fascination on PTSD and wanting to learn to treat PTSD. I applied for a fellowship in PTSD, and they said no, I couldn't. I didn't apply in time, and so I called Dr. Harvey Moldovsky, who's the grandfather of sleep medicine in Canada, and said, "Well, can I do a fellowship in sleep?" And he said, "Come tomorrow, start Monday."
Well,
And
I had the honor to come to you, to Leicester,
yes, you did. You
and
came
with
and you
you
met
and Dr.
him.
Moldowski to have
Yes,
a postdoctoral fellowship on in sleep medicine, which I
yes,
really appreciate because now I can help people. Before I wasn't,
yes.
I only
Yeah.
was able to help people with sleep apnea, but nothing else.
Yeah.
Now I
And
can.
And so Dr. Moldovsky was the first to recognize fibromyositis, which is fibromyalgia, in 1975 in conjunction with sleep polysomnograph. So in the polysomnograph at night, we actually get objective data of too much on and not enough off. So you see fragmented deep sleep, fragmented REM, and there is a fourth category beyond insomnia, initial maintenance and terminal insomnia. There is non-restorative sleep. It's a category onto itself, but it's not talked about very much because no one has medication to fix it. This book describes how we can help people with non-restorative sleep. When you have a patient who sleeps more than 8 or 10 hours and says, "Doctor, I'll sleep all night, but I wake up feeling unrefreshed," then you know they have non-restorative sleep. And what non-restorative sleep is, if you imagine, we know the regular sleep somnogram, it goes down into deep sleep, up into REM, it does that nice sine wave. When you have non-restorative sleep, you get these sympathetic bursts of fight and flight that go, wake up, wake up, wake up, wake up. It's like someone poking your shoulder all night long. How are you going to feel when you're exhausted? Wake up exhausted and in pain, because the less well you sleep, the more it activates the inflammatory system, because the stress system is just ringing all night, and you get more inflammation, and so you wake up with aches and pains in the body. And not only that, they've found in basic research that when you don't sleep deeply for a long time, the actual packaging of the lipid bilayer on your cell membranes gets damaged, which means then the second messenger systems and all the ion channels can't work properly, and the actual factory of the cell doesn't work properly. So it goes down to right to the cell membrane if you're not sleeping well. And
Our
and
our
it and it goes from birth, from conception. If a mother is under stress, the stress hormones enter the brain of the baby through the placenta, and that baby's brain gets primed to hyper activity of the sympathetic nervous system. So for me, my passion has been, it goes from cradle to grave, and sleep is important at every moment. And I'll let Jaan tell his story now.
Thank you, Celeste. And so my introduction to sleep medicine came when I was an undergraduate 50 years ago. And I was enthralled by Sigmund Freud's book, The Interpretation of Dreams. And that got me excited about sleep. I went on to do my PhD on psychological defenses and sleep. And since then, I've been working with sleep patients. I came to the cardiac rehab center 20 years ago. So I'm currently working mainly with medical patients. People have had heart attacks, who've had strokes, diagnosed with cancer, diabetes, arthritis. So a whole host of chronic medical conditions, and virtually all of them have sleep problems as well. So that's kind of been my experience in the last through my career. And I had the fortune of meeting Celeste through Dr. Harvey Moldovsky, who is our mentor. So we've known each other for about 15 years as well.
Yeah, and the beauty of the book is Jaan puts that knowledge into the book, so he actually has clinical case studies where he walks through his medical patients, and we have a list of inventories that healthcare professionals can use to assess sleep and to also assess underlying trauma that might be affecting your medicine patient. So these are all really important tools to start to incorporate if you want your patients to heal better, whether it be from physical trauma or mental trauma, and in most cases, a combination of both. But we've put a toolkit together that and an assessment inventory that will really help you get a sense of where they're at. And not only for them, but family members, because when someone has an illness or has a traumatic physical or emotional event, it affects all the family.
The whole family, the whole community, their co-workers, their students, actually the people, if they are walking and they are driving, that can be a problem. Exactly. So I I I really like your analogy. So sleep is a fire alarm, but like pain. So, like pain, but also pain can cause disturb sleep, but can sleep cause this pain?
Yes, very much
A
so.
vicious circle.
Yeah, because of the effect on the inflammatory system, so it increases pain. And if you sleep poorly for a long time, you get fibromyalgia, chronic fatigue, chronic pain. So I liken it to a double pain syndrome. Suppose you have an injury to your shoulder, you got pain, and then you don't sleep for a long time, then you get sort of musculoskeletal pain. So you get two pains on top. One, the pain from not sleeping well, and the pain that continues in your injured shoulder because the tissue's not healing well.
So the best
That's how
painkiller
important it
will be
is.
treating the sleep problem.
Yes, absolutely.
And
And then
trauma.
the other thing I wanted to say is, that Jaan and I have learned in our research is that people who have trauma where their fight and flight system is always on, they have an increased risk of developing sleep apnea. So it actually increases their risk of sleep apnea, which is so important. And Jaan, how do you describe sleep apnea at night when their oxygen comes down? You were describing it really well to me.
Yeah, so I mean, if you think about your oxygen as essential for your life, and during an apneic period, your oxygen level drops by 3% or more, and those with severe apnea, it can drop down into the 70s. And it's a bit like somebody coming into your bedroom and then putting their hands around your throat and then choking you every hour. A severe apneic patient will have 30 or more of these episodes. So every minute or two, somebody squeezing your throat and preventing you from breathing. If that was happening to you, you would tell that person to get out, leave me alone. I don't want this. But if it's an apnea that your body is doing to you, we somehow don't want to acknowledge how serious an effect that can have on our well-being.
Actually, I have seen many patients with who sleep 10 hours but only breathe 1 hour. So 7 hours without sleeping. Obviously, not all together, but this is what is happening. Every minute, 30 seconds without breathing, isn't it? Or 40 seconds?
Yep, that's
Unbelievable.
right.
That's true.
And that puts you into fight and flight. Every time the oxygen comes down, it puts your brain into fight and flight. So it's like you're triggering the sympathetic nervous system to go wake up and breathe, wake up and breathe. And
that's
so
why,
that's exhausting. You're working all night.
and exactly, and that's why sleep apnea causes insomnia, isn't it?
Yeah.
Yes, that's
Exactly.
right.
Yes.
People say, no, I don't have a sleep apnea. I don't know. Obviously, they don't know. I am tired and because I work too much. And they don't know those issues. They don't even know that they are fatigued, that they are sleepy because they think they are tired because they are unproductive. So they work a lot, but they don't develop whatever they could. And then, so yes, this is a vicious circle. And they say, no, what I have is insomnia. I wake up, I don't sleep. And yes, it's because they are every minute they wake up because of snoring,
Need the
not
oxygen.
breathing, etc., etc. So we are all intrigued and happy about the book. Tell us about the book. What inspired you to write this wonderful masterpiece? Because we were expecting this book. We all know the connection between trauma and sleep, but we never had this tool. We need to, mainly you, our patient, who wants to know how this trauma that happened 10 years, and you may precisely tell me what day it happened, is bothering your sleep until now. Please tell us about this.
Sure. Glad to. So, what inspired us to write it? So, I've been working, as I said, in the sleep field for pretty much my whole career. And I began by being trained in CBT for insomnia, which is a first line treatment, recognized first line treatment really around the world. And I use it with all patients. But what I was beginning to find is that for some patients, CBTI was not working. For many, it worked, but for some, not so well. And I think there's a recent paper that estimates that about 30 to 40% of patients, although their sleep can improve to some degree, but it does not really get back to normal. And so I was intrigued by that. And so I decided to get training in trauma therapy. And so Celeste and I went for training in EMDR, and we went to present at one of their conferences on the importance of sleep. We were shocked to find out that none of the guidelines for trauma treatment around the world, and there are many in North America, in Britain, in Australia, um, none of them mention sleep in trauma treatment. It's as if sleep doesn't exist. So I like to think of it as the orphan of trauma treatment. And so we were talking to other presenters at the conference we were at in Vancouver in 2019. And one of the presenters said, I can put you in touch with my editor. And I think she might be interested in writing a book and publishing a book on this. And so Celeste and I looked at each other. We never thought about writing a book, but we said, yeah, let's do this. So that's how it came about.
Yeah, and Norton Press is who took us on. And for those listening, our website is www.puttingtraumatosleep.com. So the same thing as the book, puttingtraumatosleep.com. And the beauty about the website is there's two sections, one for patients for more information, and then they can gain more information and tools, and one for professionals, healthcare professionals and allied professionals who want to learn more and tools and training to help their patients. And I would say for me, what really made me want to write this book was the co-author, because how often do you find someone who thinks and and breathes and lives sleep medicine in the context of a whole person, not just looking at CPAP or not just looking at restless legs. Like we look at the whole context of the person, the way our mentor, Dr. Maldowski, taught us. And my fascination has always been consciousness. Since I was a little girl, I wanted to understand the human condition. And there's a lot of resistance for people to talk about trauma or their traumatic events, but they'll be happy to speak about their sleep. So I've found that approaching people through sleep made it easier for them to open up, and then being able to give them a sleep study where I show what their brain is doing, and I show them that they have this increased sympathetic drive, that their brainstem, the fight and flight part of their brain that keeps them alive at night, is actually happening. It's not all in their head. It's actually right there. And then they do the therapy with us, and we do another sleep study, and we show them that it's improved the off system. We help them reboost their parasympathetic, their off system. And then all the aspects of their life start to improve. Like I say to anybody who doesn't understand, what it's like for a fellow person in their life who has pain, whether it be physical, mental, emotional pain, or insomnia, don't sleep for 3 nights straight, and then you'll know what they feel like every day. It's almost impossible to function. And the really chronic intractable insomnia needs the approaches that we describe in the book. CBTI won't work. CBTI is more for the acute insomnias, the people who already have good coping mechanisms, who haven't been severely traumatized. That's fine. It's like the wounded well, the people who are functioning in university, and that's where those techniques were evolved in university settings, with the university kind of focus at that level of functioning. But your average community, their trauma goes way back. And just like you said, Carlos, it's something that might have happened 10 years ago, but it's still affecting them. We're getting things that affected people in utero. When they were born, did they have enough oxygen? How were they delivered? What were their milestones like? That's what's in our inventory in the book, is like there's an inventory, and we start from cradle to old age, just the key questions you ask, just to get a sense of where their nervous system is. And we have to realize that the nervous system is dynamic. And so for the book, for me, it was just this love affair with consciousness and the brain and the nervous system. And for me, the easiest way to help people is through sleep, and the most practical way.
Wonderful, lovely. Yes, it reminds me that I think most of my patients clearly state, well, all started when I was kidnapped in 1974 or something like that, and since then, blah, 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 or when I had to pass that exam, or I had for this competition or this job interview, and since then,
when
blah.
the babies were born, that's a typical one for women.
My God, yes. By the way, because maybe some people will say trauma. That means terrible. What is a war or something? Can you tell me what is trauma? How can you tell me some examples of this trauma? How severe is this trauma?
Sure, let me begin. So Celeste and I have developed a model for treatment that includes sleep. We call it the TABS model. So the 4 initials, T, A, B, and S, stand for T is a traumatic event. So if, for example, you were in a car accident and then you couldn't sleep after that, you'd have to deal with the trauma of the accident. The A in TABS stands for attachment wounding. So there are many people growing up in their childhood had a lot of challenges in terms of their home environment. And so those create what's called developmental trauma or complex PTSD. So those issues need to be assessed and treated. The B in TAB stands for body symptoms. So feeling, having difficulty with digestion or irritable bowel, having pain in different locations. Earlier, Celeste mentioned Harvey's work on fibrositis and fibromyalgia. So, the body itself can carry a lot of stress. In fact, Bessel van der Kolk's famous book, The Body Keeps the Score, is really highlighting that in trauma, much of what the body is holding on to can be from traumatic experiences. And so those need to be taken into account in treatment. And then the part that Celeste and I are most proud of is adding the S, which is attention to sleep. You cannot treat trauma without attention to sleep as well.
Wonderful. Very, very interesting. And now people understand why putting trauma to sleep is an indispensable priority, because we're in World Sleep Day, a priority for all of us, because as you just told us, maybe the traumatic event could be just, let's say, just splitting with your ex couple. So to many people it would be irrelevant, but it may have changed the whole of your life since then because of all the taps that you just described.
Yeah, trauma is not the event itself; it's what you make of the event. So if your brainstem it doesn't have any, it doesn't contact your thoughts or your emotion. Your brainstem says, "Oh, that was dangerous for my life." If you attach to it, trauma is what you make of the event. If you know, you could. Some people can you know I've had a gun held to my head before, and it wasn't traumatic for me. Like, I didn't suffer trauma, long-term trauma after it, because of the way I dealt with it. But somebody else has a gun to their head. It's what you make of it. What you make of the event. So what the brainstem makes of the event. And the brainstem says, "Oh yeah, that was really dangerous, you nearly died." Then the brainstem's going to stay activated for a long time, and then put that activation onto other things. Like, I've been dealing with veterans for a very long time now with sleep, across Canada and internationally. And I remember one
Yes.
veteran telling me that he was coming down the escalator, and there was a guy at the end of the escalator who he thought had an AK-47, and he was going to, slide down, push everybody, and protect everybody's life. But when he got to the end of the escalator, he realized the guy was only holding a guitar. But that was his brainstem directly seeing that and reacting to it. So
And
it's trauma is what you make of it. And then you start seeing danger in other places, and it generalizes. And that it's that generalization of the brainstem being hyperactivated that then, like you said, when a couple separates, it generalizes into everything, and then it overwhelms you, and you can't sleep, and you can't sleep, and you can't sleep. And then if you don't sleep long enough, then I say the battery is like a car. You're not putting gas at night in your gas tank. So you got to push your car everywhere, and then your battery dies because that's your emotional heart. You get depressed. And then eventually your spark plugs, which is your adrenaline and cortisol, the cortisol surge that we need to wake us up in the morning, your adrenals burn out. You don't have spark plugs. So you got no gas, your battery's dead in your heart, and your spark plugs, which is the get up and go, is gone in the car. And then you say, well, my life was worthless. And you say, forget the car. It's nothing wrong with the car. It just needs to sleep, put gas in, charge the battery up, go heal the wounds in the heart, which is why we got to look at the trauma underneath, and then change the spark plugs. That's basically it.
exactly. Sounds basic now. It makes sense now, and that's why CBT doesn't work, isn't it? Only CBT
Yes.
is not
Yeah.
solving.
Oh, CBT on its own does not work. CBT is good. Like I say, CBT is like being in a room and you organize the furniture, the memories, and the reactions in the place where you're not going to trip over things, but you're still in that same room. You're not looking at the whole house. You have to look at the whole house and the foundation. And the foundation is this brainstem down here and the locus ceruleus sending danger, 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 danger messages the whole time to the brain. And that danger, 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 like we just said, puts the inflammatory system on edge. So you have more inflammation, more pain in the body. The tissues don't package properly. The cell membrane doesn't package properly. So things don't clear as well. And then you don't clear toxins as well. So, and then I also say glitchy brain, glitchy gut. And then the gut goes out of whack, and then you don't absorb nutrients better anymore properly.
So aging, inflammation, which may mean pain, cancer, of the inflammatory condition.
Yeah, well, we know the inflammatory mechanisms behind, cardiac issues and
Exactly.
hypertension. Yeah.
Okay.
MS.
Okay, perfect. Yes. So, yes, okay, that sounds perfect. That sounds fine. But yes, now what can we do with them? Because you haven't thought, do we need to buy the book, or can you give us some tips now? What can we do with those patients? Because they need
Sure. Okay, well, I think the important first point to make is that for about 50 years, our working model of insomnia and sleep disturbance has been largely behavioral. That's the CBT model, and it served us very well, just like Newtonian physics served physics very well for many years. But at a certain point, they had to move to a nuclear model, or one that was much more understanding of the dynamics, deeper dynamics of particles and electrons and so forth. Similarly, in sleep medicine, our book, I think, is the first serious book to go past the behavioral model of sleep disturbance to a model that is focused on autonomic dysregulation. And so, central to the book is the idea that insomnia, for example, which Van Someren wrote a beautiful monograph about in 2021, just a few years ago. And in the book, he made the point that insomnia is not a sleep disorder at all, because all of the neuroscience research shows that the sleep centers in the brain are functioning normally. Insomnia is actually a disturbance of the autonomic system and emotional regulation. And so that's the focus that Celeste and I took, is that if we're trying to fix the sleep, we have to be understanding what the autonomic system is doing. And so we've spent 5 years writing it to really understand the neuroscience findings. There's so much good basic science that's come out in the last 10 years, but none of it has been integrated into clinical practice. So the kinds of tools that we use to work with our patients have still largely been behavioral. And as I say, they're good, but they don't really regulate the autonomic system. So that's what we're doing, is we're providing a way of understanding the autonomic system, a way of talking about it with patients, and for them to understand that there is hope, that many of the patients that come to see me have tried treatments, CBTI and so forth, tried medications. None of those things have worked. But it's really in targeting that brainstem area, the locus coeruleus, and the associated structures nearby, that we can begin to create change at a deeper level.
Yeah. So really boosting the parasympathetic nervous system. So if a patient wants to go out now today and start, not having a therapist around to do EMDR or deep brain reorientating, what I said is go and do things that ground the nervous system, because the nervous system is like a house. It needs to be grounded. So ground your nervous system, getting in nature as much as possible. That's what dysregulated our nervous system first and foremost, was when we left nature to come to concrete jungles. So get in nature, get bare feet, they could call it grounding or earthing.
Sunlight.
And sunlight too. We know the importance of sunlight. The ancients used to do sun gazing in the morning, and that would energize. So we need to realize also that our body is physical, a biochemical, then our body's actually an electromagnetic grid. The nervous system is an electrical organ, first and foremost. The first researchers knew that when they were doing the squid axon research.
Does.
Yeah, and the squid axon. So we're an electromagnetic being. So we need to take in sunlight. We need to take in the energy that's in fresh food, pure water, not packaged foods. Stop eating all the packaged foods. And then environment is really important. The neuroemotional piece. So keep yourself in healthy environments with people who give you energy rather than drain your energy. And do exercises that boost that off system. Yoga, Tai Chi, swimming, meditation, massage therapy, things that start to boost the off. We're all in the modern world on, especially since COVID. Oh my God, there's COVID. Oh no, we're going to die. Someone's going to die.
What a pandemic we have now, a pandemic of insomnia.
Yeah, we're all in this increased sympathetic state because of that. We now need to go into the parasympathetic state where we're in genuine relationship with ourselves, genuine relationship with others, because that feeds the heart and the soul. And I love it. One of the veteran groups that I work with, their motto is PTSD is a disorder of the brain and mind that you heal with the heart. And from the Institute of Heart Math, they've shown that the electromagnetic field around the heart is 40 to 100 times stronger than the brain. So I would say go get some really good loving, whether you love yourself or be around people who love you. And you're going to already, and be with fresh air and fresh food and in nature. And you're already going to sleep a little bit better, because it's going to bring down that hyper sympathetic tone.
Well, this is fantastic. I love your discussion because many people, my audience, your audience, are thinking about many things. That's why benzodiazepine doesn't work, and it's stupid. Isn't it that very very
No,
stupid?
well, the truth is your brain is wired, your brainstem is wired to save your life. So the benzodiazepine or the antidepressants might work for a bit, but then the brain goes, no, 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 there's danger. I got to save your life. I can't let you sleep. So it's so smart. It rewires itself around the medication and then keeps you awake, which
And
is why we need to do rewiring ourselves. And in our therapy and how we help people, we're helping them to that's why under our book is called Putting Trauma to Sleep, Attachment-Based Neuromodulatory Interventions for Stabilizing the Brainstem. We are helping people to neuromodulate themselves, to bring the brainstem back into balance, to bring the autonomic nervous system back into balance so that they can sleep again and have amazing lives.
And this is the scientific answer why breathing techniques, yoga, Tai Chi works. Can you explain this to our audience? Because some people will say, well, if there is a imbalance between sympathetic and parasympathetic, why don't we use, for instance, beta blockers? Can you explain how we can get the right balance with breathing techniques?
Yeah, so I'm going to explain from the yoga Tai Chi point of view, and then Jan's going to explain by a simple breathing technique that shows how people have imbalanced their autonomic nervous system. So we said, remember, the autonomic nervous system is too much on and not enough off, right? So first and foremost, I want people who are watching to try to breathe out of one nostril. You try that, and then try and breathe out of the other nostril. Is there one nostril that's easier to breathe through?
Yeah.
Which one?
This one.
Okay. Your brain changes that every 90 minutes. Every 90 minutes, it makes it easier to breathe out of one nostril or the other. And that's so that each hemisphere of your brain gets full aeration. And I didn't learn that from neurosurgery training or psychiatry training. I learned that in yoga class. They do yoga exercises that breathe from the different nostrils so that they regulate the hemisphere, and they also regulate the sympathetic and parasympathetic nervous system. The ancients were brilliant. They knew the importance of on, but they also knew the wisdom of off. And they knew that both part of the systems, the sympathetic, parasympathetic, the yin, which is parasympathetic, the yang, which is sympathetic, they knew the importance of balance of on and off. So all their exercises and breathing techniques and mantras are there to keep this beautiful balance of the on and off system.
Exactly. Now, people can understand why doing this, which is what we always recommend, is not only blah, blah. It makes sense. It has a scientific reason to work. And obviously, this is the solution. It's not beta blocker. It's not, that is not the solution.
And Jan's going to tell you about a breathing technique and the breathing that happens with traumatized people, whether it be physical or mental trauma. Jaan?
Yeah, thanks, Celeste. So one of the things I've seen in the work that I do with insomnia patients, and I've been doing this work now for, gosh, about 40 years, is if you look at their breathing patterns, that people with insomnia tend to breathe from the chest. So they're breathing up here. It's a shallow breathing pattern. And in contrast, when a baby is born and comes into the world, and we've all come into the world breathing into the belly. So if you watch a baby sleeping in a crib and watch their bellies, they're like balloons. They go up and down. So we're meant to breathe diaphragmatically. But with all the stress and pressure that we experience through a long life, we begin to get tense. Our muscles get tense. We anticipate danger. We hold our breath. And so we begin to breathe in the chest. And so one of the things that we highlight in the book is that we can easily assess, are you mainly a chest breather, a shallow breather, or are you breathing into the belly? And then based on that, we can direct the patient to do some breathing exercises in order to get the breath down into the belly. So until they accomplish that important step, their nervous system it's stuck in that on position that Celeste was talking about, sympathetic overdrive or hyperarousal. And when you begin to get the air down into the belly, now you're activating the parasympathetic. So I've been teaching all of my sleep patients to do the breathing, and that often takes about 2 weeks of time of regular practice of getting the breath down into the belly, and it changes their nervous system. It
You get
changes their
them to,
sense of agency.
yeah, you're teaching me that you get them to lie on the floor, right? And put their hands on their belly and breathe from their belly and their hands first, and then fill their whole lungs up, correct?
So let me
Yeah. So yeah.
let me try to see if I understood well, and my lay community also can understand. Okay, so if I am sleeping and I have this sympathetic overdrive, my heart rate will be higher,
Yeah.
and maybe my blood pressure could be higher, and maybe I have risk of an arrhythmia, atrial fibrillation, a heart attack, a stroke, isn't it? And in the long
Yeah.
term, diabetes, obesity, all that. So all this imbalance, okay, I can regulate it not with beta blockers reducing the sympathetic, but increasing the parasympathetic, which is breathing with the diaphragm, which goes to the parasympathetic centers, and this is the solution. And it
Yes.
works. Believe it or not, my dear patient, it works. Try tonight, and you will see in a few minutes that breathing like you should helps, and you fall asleep in a few minutes, isn't it?
It's yes, but people who've been kind of stuck in that chest breathing pattern, most of them will take a week to 3 weeks to get the regular breathing pattern down into the belly, right? So they have to practice. It's almost like you have to retrain the muscle groups around the lungs because the lungs themselves don't pull any air in. They depend completely on all of the muscle groups around. So the diaphragm is a big part of it. The intercostal muscles between your ribs, your shoulders, your chest, all of those have to work in unison, but they have to get the air down to the bottom of the lungs. And so that's where, as Celeste was saying, I ask people to do the exercise lying down on the ground. And then actually, if they're chest breathers, I ask them to put their arms above their heads and then stretch the hands out like they're reaching for a piece of chocolate, right? And why they do that is now you're pulling the chest up, so you can't cheat. You can't use these muscles to breathe. Now you have to breathe with the diaphragm and the abdominal core, and getting those two muscle groups to activate and to become more present through each of the breathing exercises. Each time you do it, you're training the muscles to be a little better, a little better, a little better. But it takes about 2 weeks for most patients.
Yeah, I didn't say that it's easy, no, but it works. It works. Actually, you can do it now. You can stop breathing for a few seconds. Your heart rate will stop and breathe properly. And this is like the Valsalva maneuver. So it works. It immediately reduces your heart rate. So this is scientific way to explain what is happening behind all this. Okay, we understand the brainstem, we understand parasympathetic, sympathetic, hyperarousal. By the way, give me just a second. I want your answer about this. Are those polysomnography, those sleep tests with this hypnogram, are they useful? Do we need them? Is it a good tool to diagnose or because people say, okay, why did you request that test, which is expensive? Because you just told
Absolutely.
me what I told you yesterday. I don't sleep. I wake up every whatever. Are they useful?
Absolutely. Very, very useful because you see just how severe the autonomic nervous system dysregulation is. You see just, I have patients who have no deep sleep and no REM sleep, and they were brilliant IBM programmers, and now they can't even read a sentence and remember it. So it'll tell me the severity of it. And like I said, it shows the patients it's not all in their head, it's actually their nervous system. And the good news is we can help your nervous system recover and your sleep can recover so they feel more empowered. We give them tools to help make the change. So, they don't have to feel like, oh, I'm some head case who's depressed and I just can't, it's up to me because I'm just not strong enough to make myself go. I say, well, how can you make yourself go when your gas tank is empty? When you're not getting deep sleep, and here's the evidence. And then they can show their family members, and their family members aren't as judgmental against them anymore because they say, oh, it's in your physiology. It's what your brain is doing. No wonder you're exhausted because you're not sleeping. So it really helps remove a lot of shame and guilt, but also gives empowerment. Jaan, what's your experience?
Yeah, no, I do think that the polysomnogram is very helpful information. And in the book itself, we actually, in one of the chapters, we talk about how to look at the results. I think in sleep medicine today, most of the time, the only thing that's looked at is whether your apnea hypopnea index is, above 15 or 30. But the actual report and the sleep staging and the amount of time you're in the stages and how many arousals you have through the night and how disrupted that beautiful ultradian, that 90-minute cycle is, all of that is very rich information, which tells us about the status of the autonomic nervous system itself. It's largely being ignored, I would say, by many sleep medicine specialists because they have very busy schedules, a short time to talk to the patient, so they focus on the apnea. But in the book, we talk about how you can look at the sleep report. And so patients who are interested can get a copy of the book and look at how we describe the features that are important to understand and get a sense of that for themselves.
Wonderful. Thank you so much. You helped me a lot. I will in each consultation show this video to them. So now we understand this and that and brain stem, the sympathetic, parasympathetic, heart rate and all that, and breathing and all. And now trauma. Tell me about trauma.
So I'll start. So when I began doing, when Celeste and I began writing the book, and we began to understand that the autonomic system is what we have to target, I began looking around for treatments that work. And as I mentioned, both Celeste and I trained in EMDR, and I used it with many patients. I had one patient whose story is in the book, who I treated with EMDR. He had been in a car accident. And other than the car accident, he had been healthy and required no psychiatric attention. And he got better. His sleep improved after his car accident. He was sleeping 2 to 3 hours a night. Very, very fragmented, very short sleep, very difficult to treat. Certainly CBTI would not work with that kind of a sleep pattern. But he did get better. And then what happened after the 1 year anniversary of his car accident, his sleep problem came back. And I began to realize that EMDR does very important work in integrating the left and right hemispheres, right? So the right hemisphere is holding your emotional world, your body sensations. Your left hemisphere is where your image of yourself, your autobiographical self and memory is located.
Don Valley Parkway South, Gardiner Expressway West, Toronto. Sorry. 100 meters.
So the left and right hemispheres are integrated through EMDR, but the EMDR may not actually get down to the brainstem. And so I was lucky enough to find a psychiatrist. His name is Dr. Frank Corrigan, who's been working with trauma his whole life. And in particular, those patients who dissociate, who struggle with remaining in the present or in dealing with their body sensations. And he's developed a treatment that really does reactivate the brainstem and begins to target the shock reactions that locus coeruleus activates. So again, earlier I was talking about survival, and in a trauma situation, that survival brain gets reactivated, it gets triggered, and because the situation is often overwhelming, it doesn't let go. It locks in those experiences. And some of that are these shock reactions into the body. And what Dr. Frank Corrigan's psychotherapy, which is called deep brain reorienting work. So in the work, you are grounding the patient in a safe place, and then you are going back to the trigger, what happened to them. And then they're tracking and noticing what they experience in their own body. So the trauma work is actually kind of bringing their attention to something that's been there, but it's kind of been hidden or not noticed. And so as you do that repeated, uh, reopening of these moments of overwhelm, the brainstem begins to release or let go of these reactions, and your neuromodulatory effect is coming from the treatment that you're providing across a number of sessions.
Wonderful. So, putting trauma to sleep.com. It seems to be a bestseller soon, isn't it? So tell me a bit more. How can people get help with the website, with the book, patients particularly, but not only them? You, my colleagues who want to learn more about this, how can you help them? Patients,
Well,
community in
first,
general, and colleagues?
yeah, first and foremost, Carlos, we want to partner with Sleep Care and offer a webinar in May. So we can offer a webinar with you for our sleep colleagues and bring them into the actual more detailed neurobiology, sleep medicine of all of this, so that they can then better know how to help their patients in an immediate way. But then also for the patients, we will be launching an 8-week seminar that's group work that will take them through the various exercises, like the breathing exercise and other exercises that they can do to already start addressing their sleep issues. So in the next few weeks, we'll be releasing those dates, and through you, we'll advertise them. But definitely, we want to work in conjunction with Sleep Care to bring this to the world, because you are foremost sleep platform in the world, and I saw you from the very beginning develop it, and I just have so much respect for you and your team and everything you do. So I would say that come to the website, puttingtraumatosleep.com. We will be putting those dates on, but definitely the webinar in May will help.
Link our websites, yes.
Yes, exactly. We'll do that. We'll link it, and then there will be ongoing workshops to give patients toolkits. And then Jaan and I are only 2 people, so we need to train professionals how to do the treatment, right, Jaan?
This one first, this one here.
Yes. Yeah.
So a webinar for doctors or health care professionals?
Professionals, yes.
For free?
In May. In May.
For free?
For free in May, yes.
Unbelievable, huh? And a 8-week program for patients.
An 8-week program, 1 night a week for 8 weeks, that we will also start in May for patients. Now that there'll be a cost for that, but it won't be exorbitant because it's a group.
Incredible. Many people will come to see us, definitely. Well, any closing comments that you would like to stress or that we didn't cover now today? We have a lot to
Yeah, I think we've done so much and covered so much, and I think Jaan is frozen, unfortunately. So hope he'll come back to us.
No, I can see him.
He's frozen. Yeah, he's frozen. Nobody's frozen. He hasn't moved in 3 minutes, so he's frozen. So I would just come back to what my grandmother would say. If you're not sleeping well at night, you ain't at peace in your heart. So something's wrong in the system, whether it be emotionally, you're not at ease in your heart, or physically. So if you're not sleeping, you need to see a sleep specialist. And you need to start looking at what it is that's causing or underlying the sleep problem, which is what we're trying to empower patients to do so they can take control of their health. And then we're trying to educate allied health professionals so that they can educate their patients and optimize their health and improve their physical recovery from mental and physical illnesses. You and I both know from the conference way back in 2013 when the doctor from Hong Kong, sleep specialist, presented his data on, how it affected GERD, how it affected arthritis, how insomnia affected pain. So all of this is affecting every aspect of their life.
Everyone, I agree.
And that's why World Sleep Day is so important. We need to keep on educating the world about sleep. And thank you for having us. And I know Jaan would say thank you too.
Yes, so I'm not sure if I'm still frozen or if you can hear me.
Oh, you're good now. Yes.
Okay, great. So I want to thank you, Carlos, for having us on. And I think for World Sleep Day, the whole purpose of it is education and for people to understand that things can change, that they're not stuck with certain problems that they may have had for decades, like poor sleep. So things can change. So there is hope.
Well, I really, really thank you both because of this wonderful webinar. Happy World Sleep Day to all of you, and see you next month. I look forward to see you both, Celeste and Jaan, next month. And please prepare your questions, your idea, your thoughts, your comments. Write to us. Put in traumatosleep.com and sleepcareclinics.com, and we will answer your questions soon. Thank you so much. Thank you.
Nos vemos. Ciao.
Thank you.
By the way, Spanish, French, Portuguese. Do you have it in Spanish? Do you want to write it in, or I think it's
yes, we
audio.
want to translate the book into Spanish. Absolutely.
Thank you.
Excellent. Muy bien.
Hasta el próximo mes. Bye bye.
Hasta la próxima. Gracias. Ciao.
Okay. Arrivederci.